Great. Well, welcome everybody. Today we're gathered at the, this is the 32nd anniversary of the Da Silva comb procedure that, as you know, revolutionized the care of patients with Epstein's anomaly, the true repair. It is a special honor for me to welcome you all on behalf of the course directors. And we are very, very privileged to have several speakers today, both from our institution and from other places in the world. Also being very grateful for our partnership with the Congenital Heart Academy that's transmitting this symposium all over the world. So in this special event today, this is our fifth Epstein Symposium. We're going to be starting with Professor Bob Anderson. As you know, Professor Anderson is a pioneer in cardiac morphology and developmental biology of congenital heart disease. And we are honored he has currently an affiliation with the University of Newcastle. But the truth is, Professor Anderson has been affiliated with many, many places all over the world. And I could even say that we should hold him as faculty in Pittsburgh, since there's a long history of Professor Anderson spending months with us in Pittsburgh in the starts of our program, working with the heart specimen collection that we have here. So it is a true honor to have Professor Bob Anderson start. He'll be talking about morphology of Epstein's anomaly. And at the end of the presentations, we'll have the opportunity of ask questions directly to our speakers. So feel free to enter any questions you have in the Zoom, in the chat, and then we'll address them immediately after each presenter. Thank you. With no further ado, Professor Anderson.
Well, good morning to you, ladies and gentlemen. My name is Bob Anderson. It's a pleasure to be with you this morning. And indeed, it's a pleasure to be joining you again in Pittsburgh. I have strong connections with Pittsburgh. I've been coming through Children's Hospital now since 1979. So what I've been asked to talk to you today is Epstein's malformation, specifically the development and the anatomy. But it's appropriate if I start by telling you just a few things about Wilhelm Epstein. As you can see, he was born in 1836 in Prussia. And at that time, Prussia also owned East Prussia. And he went to university initially in Breslau, which is now in Poland. He continued his studies in Berlin, but he returned to Breslau to start his career as a physician. He wasn't there long because he made great strides, and already by 1874, he was sufficiently well recognized to be appointed as the professor of medicine at Göttingen, perhaps the leading medical university in Germany. And he stayed in Göttingen the remainder of his career. But what we are talking about today should perhaps be called Presche's malformation, because it was Josef Presche who came into the hospital in Breslau, where Epstein was working, and attracted his attention to the lesion we now name in honor of Wilhelm. Josef was 19 years old. He was complaining of shortness of breath, palpitations. He'd had them since he'd been a child. He was blue. His heart was big. It was full of murmurs. Sadly, he didn't last long in the hospital and died about a week after his admittance. And this is why we now remember Josef Presche. These are the drawings that were made by Dr. Weiss of the heart that was seen at the autopsy that was conducted by Wilhelm Epstein. Here you're looking at the inlet aspect of the abnormal heart. You see there's a small remnant of the septal leaflet, and there's a tongue of tissue that joins together the anterosuperior and the inferior leaflets. And the consequence of this is that the valvar orifice is looking into the outflow tract of the right ventricle. Here is the outlet view of the malformed valve, and now you see that remnant of the septal leaflet. And the anterosuperior leaflet has a linear attachment. And in consequence of this linear attachment, the valve closes in bifoliate fashion. And that is the feature I'm going to be emphasizing for you. So if we are to understand the abnormal anatomy that we're going to be looking at, we need to make comparisons with normal tricuspid valve, because that will permit us to understand the variations I'm going to emphasize. But as I intimated, we're going to start off by looking at what happens during development. And I've been learning a lot about development over the past 12 months or so, because I've had the privilege of working with Wout Lammers and Jill Hicks-Poors from the University of Maastricht. And Wout and Jill have made interactive PD files that show the development of the human heart throughout the period of embryonic development, which lasts from 4 to 8 weeks of gestation. And this is a reconstruction they've made of a human embryo at the end of embryonic development, what we call Carnegie stage 23, when the embryo is 8 weeks old. In yellow, you see the atrioventricular canal myocardium. By now, this has been sequestrated to form the vestibule of what will be the tricuspid valve. There you see the right ventricular aspect of the muscular ventricular septum, and to the top of the screen, you see the underside of the leaflets of the developing pulmonary root. By now, the proximal cushions that separate the outflow tract into the aortic and pulmonary channels have muscularized, and they've committed the aortic root to the left ventricle. But here is the focus of our attention. That is the developing tricuspid valve. And I hope you will immediately note that it has only 2 leaflets at this stage. We can confirm that by looking at serial sections, and this is a serial section through a data set from the Human Development Biology resource that is now available for study in the United Kingdom. It's a little younger than the embryo I showed you a moment ago, Carnegie stage 22. It's a 4-chamber section. But what we see there are the fused atrioventricular cushions that will form the membranous septum, but they will also delaminate to form the septal leaflet of the valve. But as yet, there's been no delamination. There is the lateral cushion, which will form the anterosuperior leaflet. I can now return to another data set from the Human Developmental Biology resource, and this time we can look at it in the same cutting plane as I showed you in that reconstruction that was made by Wout and Jill. So there you're looking into the right ventricle, and there you see the aortic root. So it's the equivalent of the oblique subcostal cut made by echocardiographers. And there, at the level of the atrioventricular junction, you see the undelaminated septal leaflet, and there you see the line of union between the superior and the inferior atrioventricular cushions that have formed this leaflet. You can also see the anterosuperior leaflet. What I want to emphasize is the angle between the atrioventricular junction, which when we look at the heart attitudinally is vertical, and the level of the hinge of the anterosuperior leaflet. And you see it's rotated away from the atrioventricular junction at the inner heart curvature. And that now separates the inlet from the apical trabecular component of the ventricle. And as yet, there has been no delamination of the leaflets, so that the effective valvular orifice is between this inlet component and the apical component and is looking towards the infundibulum, just as it was in the heart of Joseph Pressure. So the key to development is the delamination of the leaflets that lift the valvular orifice back to the level of the atrioventricular junction. Now, if we look at the normal tricuspid valve, we can appreciate that The normal valve does have 3 leaflets, and that is because with normal development from the stage we looked at in embryonic development, there is the formation of the 3rd leaflet, which is located inferiorly. We can see that in this rather nice virtual data set made of an adult by my good friend and colleague, Shunpei Mori. Shunpei made this whilst he was working in Kobe in Japan, but now he's working at the University of California in Los Angeles. And these virtual data sets show us anatomy as it should be seen in the context of the living heart. So there you see the anterosuperior leaflet, the septal leaflet, and now we see that 3rd leaflet of the valve that is formed subsequent to the end of embryonic development, and it is positioned inferiorly. It is not posterior, although that is still as it is often described. The key point now, with formation of that inferior leaflet, the valve will close in trifoliate fashion, and that, of course, is why we call it the tricuspid valve. So if we look at it in the same aspect as I showed you in the developing heart, this is one of the beautiful images made by Diane Spicer. Diane also started her career in Pittsburgh, and Diane is emphasizing when we photograph the heart in attitudinally appropriate fashion, the atrioventricular junction is vertical. And the union between the inlet and the apical trabecular component is angulated away from the inner heart curvature. And that permits us to understand what is going on when the valve is malformed. Now, time is not going to permit me to discuss with you any great detail the features of valvar dysplasia. I will briefly mention segmental combinations and associated malformations, but what I want to emphasize is the anatomy itself in the setting of Ebstein's malformation, in the setting of concordant atrioventricular connections, because the key to the variation is the location of that valvar orifice. And this goes back to some work I did with Christian Schreiber. Christian's sadly no longer with us. He came and he worked with me at the end of the 20th century whilst I was still at the Brompton Hospital. And we looked at 23 examples of Ebstein's malformation. And when we put in the location of that valvar orifice, as I've shown you, it is displaced away from the atrioventricular junction in rotational fashion. I know that echocardiographers talk about downward displacement, but when we put this displacement in the setting of the heart within the body, the rotation, it is a rotational displacement rather than a downward displacement. And it is the variation in that rotation that is the key to understanding. So this, in fact, is one of the hearts from the Pittsburgh archive. And I cut my teeth learning about Ebstein's malformation in the archive at Pittsburgh Children's Hospital. So there you see the anterosuperior leaflet. And just as in the heart of Joseph Prescher, there is a tongue that joins together the conjoined septal and inferior leaflets with that anterosuperior leaflet. And now you see beautifully in this specimen the rotational displacement of the conjoined septal and inferior leaflets away from the plane of the atrioventricular junction. And it is that rotational displacement that gives us this bifoliate configuration of the malformed valve. And we see that beautifully in this heart also, that is remarkably reminiscent of the drawing that Wilhelm Ebstein made of the heart of Joseph Prescher. So there in this heart, you see how the valvar orifice, the keyhole, is looking into the infundibulum of the right ventricle. And it is closing in bifoliate fashion by consequence of the linear attachment of the anterosuperior leaflet. But the anterosuperior leaflet is not always attached in linear fashion. So in this example, which to me as a morphologist, is less severe, we have focal attachment of the anterosuperior leaflet. You can see there the anterosuperior leaflet with a normal attachment between the medial papillary muscle, the anterosuperior papillary muscle. And there you see that the septal leaflet, the inferior leaflet in this particular heart are deficient. There is far less valvar tissue formed, and it would be much harder in this heart for the surgeon to make the cone of valvar tissue that is the essence of the procedure described by Dr. Da Silva. So we see, in fact, the potential to form the cone of valvar tissue much better when we have this linear attachment of the anterosuperior leaflet, and the keyhole is looking into the infundibulum of the right ventricle. And now we see the atrialized inlet component with that linear attachment of the anterosuperior leaflet, the connecting tongue with the inferior leaflet. And the task of the surgeon now is to do what the embryo was trying to do, to try to return that valvar orifice from the union between the atrialized inlet to the level of the atrioventricular junction. And so it is when there is this linear attachment of the anterosuperior leaflet that the surgeon will be best placed in creating the cone of leaflet tissue that is the essence of Dr. Da Silva's approach to surgical treatment. On occasion, however, we can have an imperforate Ebstein's malformation, and that is because the keyhole is closed. So the key to surgical variation is that distal attachment of the anterosuperior leaflet, and it is a spectrum of malformation. The focal attachment, when it may well be much harder for the surgeon to create that cone of leaflet tissue, hyphenated attachment to that linear attachment, which is, in my experience, the most usual surgical variation, remembering that on occasion the valve can be imperforate. A couple of other key surgical points to bear in mind. We find the atrioventricular node where we expect it to be. It's at the apex of the triangle of Koch, because the triangle of Koch itself will not have been distorted by the presence of Ebstein's malformation. We should also remember the right coronary artery, because of course the right coronary artery is within the right atrioventricular junction, which is going to be markedly dilated in the setting of florid Ebstein's malformation. So there's always the danger of kinking that right coronary artery when the surgeon seeks to reduce the size of that right orifice. Now, thus far, I've only spoken about Ebstein's malformation in the setting of concordant atrioventricular connections, but we all know that when we have congenitally corrected transposition, and when in usual atrial arrangement, tricuspid valve is left-sided, then in the majority of cases, left-sided tricuspid valve shows features that have much in common with Ebstein's malformation, not identical. So now we call this the Ebsteinoid variant. And very rarely, however, the mitral valve can show evidence of Ebstein's malformation. But then, in the setting of Ebstein's malformation, it is the mural leaflet that is displaced rather than the septal leaflet. Don't forget the associated malformations. In most instances, there will be an atrial septal defect. Much more rarely, there can be a ventricular septal defect or even an atrioventricular septal defect. Pulmonary stenosis is frequent. When we find pulmonary atresia in the setting of an intact ventricular septum, then again, Ebstein's malformation of the tricuspid valve is a frequent finding. And for the arrhythmologists, we must remember that because the malformation deforms the right atrioventricular junction, in many cases, we have Wolff-Parkinson-White syndrome. So if I summarize The major point to bear in mind is that there is displacement of the septal and inferior leaflets, and that reflects the failure of delamination during development. But that displacement is rotational, although when seen in echocardiographic images, it seems to be downward. The consequence of the displacement, the valvar orifice, is a keyhole in florid cases, and it's looking into the infundibulum. It is at the junction between the atrialized inlet component and the functional right ventricle. What I hope I have emphasized is that as far as the surgeon is concerned, the major variation involves that distal attachment of the anterosuperior leaflet. And it's perhaps a paradox that when I see less well-formed cases with focal attachment, it might be harder for the surgeon in this instance to make the cone of leaflet tissue, but as I've emphasized, is the essence of the repair that was put forward and has revolutionized the treatment, the repair put forward by Dr. Da Silva. Remember, Ebstenoid malformation is frequent in the setting of congenital corrected transposition, and don't forget those associated malformations, but the major take-home point, the lack of delamination of those septal and inferior leaflets has given rotational displacement of that valvar orifice that typically is a keyhole looking into the infundibulum of the right ventricle, just as it was in that heart of Joseph pressure seen by Dr. Epstein so long ago. Thank you so much for permitting me to share my experience with you, and I'm looking forward to the remainder of this exciting seminar.
Thank you very much, Professor Anderson. That was fantastic, as always, so nicely explained and incredible pictures. I think there is a question from the audience, from the chat, about how would you differentiate imperforate Epstein's anomaly with a tricuspid atresia?
Well, of course, one wouldn't differentiate them because they would both, the imperfect Epstein's malformation is producing tricuspid atresia. When I started my career, in fact, it was often thought that tricuspid atresia was due to an imperforate tricuspid valve. We now know, of course, that is rarely the case. The majority of cases that we see with what we might call garden tricuspid atresia have absence of the right atrioventricular connection, and they're a variant of the functionally univentricular heart with dominant left ventricle. So garden tricuspid atresia is a close cousin to double inlet left ventricle. When we have the imperforate valve in the setting of Epstein's malformation, of course, that's a totally different kettle of fish. We have biventricular connections, and then the substrate is the imperforate valve. We can also see imperforate valves when we have pulmonary atresia with intact septum, but the majority of cases of tricuspid atresia, without question, are the functionally univentricular variants with dominant left ventricle and incomplete right ventricle. But they're all examples of tricuspid atresia.
Wonderful. Thank you. Is there a question? Yes, Dr. Da Silva.
Hi, good morning. This is José da Silva. It's always a pleasure to have you here, Dr. Bob Anderson, the Professor Bob Anderson. I was looking in your presentation about the displacement, the rotation of the annulus. When we have extreme rotation, that the valve is very near the outflow tract and very near the pulmonary valve, we noticed that those patients have more problem with the myocardium itself. So the structure of the heart seems to be much worse, and they give a hard time to the surgeon to keep a good function afterwards. In your experience as pathologist, have you noticed that those patients die young because of the bad myocardium or the bad malformation? That's one question. And the other one is about a case that we had here where the patient had valve, a workable tricuspid valve like Epstein morphology. But then the myocardium was nothing, it was just fat. I don't know if you call that different disease, you call who disease, or what do you think? It's interesting, but many people don't know. I didn't know exactly. I didn't do the operation, of course. I did other intervention, but because we didn't have any myocardium. So those are the two things that I want to make some comments, please.
Well, the question, I'm not a perfect person to answer them because rather than being a pathologist, many people think that I'm a pathologist. In fact, I'm trained as an anatomist. So my knowledge of pathology is somewhat limited. It's limited to the congenital malformations that fortunately depend very much on anatomy rather than pathology. But the questions you pose are very good ones. In fact, I think it was established quite some time ago that Ebstein's malformation is really a global disease. And it involves not only the myocardium of the right ventricle, as you point out, but also the myocardium of the left ventricle. And it's another connection back to Pittsburgh that takes us back to the realization of Ebstein's as a global phenomenon, because it was Dr. Manebe a long time ago in the 1970s when initially he was a fellow here working with my late lamented friend Bob Zuberbuehler and with Bob Matthews, who was here at the time. And they noted that the left ventricle was very often involved, the right ventricle, as you point out, Dr. Da Silva. The myocardium of the right ventricle is diseased throughout. And I think that also reflects your other point you make with the fatty replacement of the right ventricular myocardium. And that, of course, is now what we know as right ventricular dysplasia. That's recognized as a cardiomyopathy in its own right. And it's not surprising that in some instances, the cardiomyopathy would coexist with Ebstein's malformation. So I think it does point to the fact that the disease itself is a global problem, reflecting not just the tricuspid valve, but the entirety of the ventricular mass. But that's the best I can do. I describe what I see. I think it's up to the molecular biologists who can perhaps look into the background to see what is going on and why it's all happening.
Wonderful. Yeah, and to follow up on that same subject, you think that there is sometimes described association with non-compaction also, I mean, it tells you that this is just not a simple problem. This involves the muscle all over the heart.
Indeed. And in fact, the association with what you call non-compaction is a very good one, because in fact, we now know that what is called non-compaction is in reality excessive trabeculation. There is no evidence whatsoever that the trabecular myocardium comes together to form the compact wall of the heart. But it does come together. It forms the septum. It forms the tension apparatus of the atrioventricular valves. It forms the conduction system. So unequivocally, there is an association with excessive trabeculation. And perhaps that explains why, when the trabeculations are not coming together properly to form the leaflets and the tension apparatus of the atrioventricular valves, that is why the leaflets themselves are not able to delaminate. So I think that's a very good association that you bring to mind. But I would emphasize again, it's excessive trabeculation rather than non-compaction.
Good, wonderful. Lesson learned. Okay, so wonderful. I think we're going to have to proceed with the rest of the program, but there will be ongoing opportunities to send more questions through the chat, and that we can send to Professor Anderson if there's anything else that you'd like to bring up. I'm going to introduce the next moderator, and that's Dr. Tariq Al-Said. Dr. Said is Associate Professor of Pediatrics here at the University of Pittsburgh and also directs the Fontan Management Program here. And he will be introducing the next presenter. Thank you.